Hello colleagues, my name is student Dr. Paul Hunt, and I am a second-year medical student at Idaho College of Osteopathic Medicine. Today, under the leadership of Dr. Kuo, and with reference to the American Urological Institute guidelines, we are going to explore the medical and surgical management of kidney stones. Kidney stones affect about 9% of the American population, so I'm sure as a primary care physician, you've encountered patients with them before. Knowledge of the current updated guidelines on their management is crucial to ensure the best quality of care for your patients. First, we wanted to start off the video with a case that's representative of what you may see in one of your patients. Here is a case of a 30-year-old patient presenting to your clinic for a follow-up from a prior renal ultrasound. She initially presented with the chief complaint of back pain. We want you to keep this case in mind as we go through the presentation, and feel free to pause the video to go back and review the case. Before we dive further into the treatment and management of kidney stones, we must review their anatomy and pathology. We'll focus especially on the different types of stones and where and how they develop. Calculi can form in any part of the urinary tract, including the kidneys, ureter, bladder, urethra, and prostate. Today, we're mainly going to focus on renal calculi. Patients may not present with any signs or symptoms, or they may arise in conjunction with complications from irritation or movement of kidney stones out of the renal pelvis and into the ureters. There are 5 general stone types: calcium oxalate, calcium phosphate, uric acid, struvite, and cysteine. Calcium oxalate and calcium phosphate are the most common stone forms, and they are associated with diseases such as diabetes, insulin resistance, and Lesch-Nyhan syndrome. Uric acid stones may arise as an adverse drug reaction for chemotherapy patients being treated for either leukemia or lymphoma. Struvite stones, also known as magnesium ammonium phosphate stones, are associated with infections. Cysteine stones are genetic, and the inheritance pattern seen in patients is autosomal recessive. In patients with these genetics, higher levels of cysteine are seen in the urine than those without. Cysteine stones can be differentiated from other calculi by the presence of sulfide bonds. The presence of cysteine stones also varies based on urinary pH. While they are more prevalent at lower pHs, they are not soluble until a pH of 9.6. It is important to take a good medical and family history in order to narrow down your differentials and determine the cause of a patient's kidney stones. The prevalence of kidney stones is heavily impacted by a patient's diet and lifestyle. It has been found that increased fluid intake and modification of diet to reduce sugar and animal protein intake and increase calcium intake reduces the occurrence of stones. Men develop stones more than women. However, this gap is narrowing, likely due to a disproportionate increase in kidney stones developing in women. Medications have also been shown to increase stone risk. Topiramate is an example of a drug that has been used in the treatment of migraines and has been shown to increase stone risk in both pediatric and adult populations. It causes the pH in a patient's urine to increase while also decreasing the concentration of citrate. This results in an increased risk for the formation of calcium phosphate stones. Another drug that may lead to the development of kidney stones in neonates is furosemide. Discontinuing usually resolves this issue. A history of stones is a significant risk factor as well. Patients who have had a stone before have a 50% chance of developing another one in their lifetime. Classically, stone patients present with flank pain. This pain can radiate to the anterior abdomen or groin, and hematuria can be associated. Nausea and vomiting are other common occurrences. It is also very important to question any association with fever and chills. As the stone migrates, patients can also develop lower urinary tract symptoms such as frequency and dysuria. Chronic stone disease can sometimes present with recurrent urinary tract infections. In the case of staghorn stones, these may be caused by urease-producing microorganisms including Proteus, Staphylococcus aureus, and Pseudomonas, which leads to the alkalinization of urine. A history of stones is important as patients who have one episode of stone have a 50% chance of developing another one in their lifetime. When determining a differential of kidney stones, presentation can vary based on the individual and the location of the stone. Patients most commonly present with radiating flank and groin pain. When a stone descends down the ureter, patients may experience pain at its approximate level. Upon physical examination, you might find a patient who is constantly moving, trying to find a position that eases their discomfort. There may be tenderness at the costovertebral angle or the lower quadrants of the abdomen. It is important to note that these symptoms are nonspecific, and further investigation and imaging must be done in order to support a diagnosis of kidney stones. Common symptoms of kidney stones may include fever, hematuria, back pain, and dizziness. Other diagnoses to consider are hydronephrosis, bacterial cystitis, possible rib fractures, and referred pain. Returning to patient X, both history and physical exam revealed radiating pain at the costovertebral angle and tenderness in the left lower quadrant upon palpation. The patient also claims to have a healthy lifestyle. Now that you know a little bit more about this patient, how might we work this patient up? The first thing that must be considered is the severity of the kidney stones and whether urgent intervention is needed. When stones are suspected, clinicians should perform a detailed medical and dietary history and obtain a serum chemistry and urinalysis. A detailed medical history could reveal a predisposition towards developing stones, with conditions such as renal tubular acidosis type 1, diabetes mellitus type 2, primary hyperparathyroidism, bone disease, and malabsorptive gastrointestinal states due to gastric bypass and various other surgeries. Contributory dietary history includes low fluid intake, low fruit and vegetable intake, and high sodium intake. An important test to assess the risk of stones is a basic metabolic panel, which includes calcium and creatinine. Urinalysis can assess urine pH and identify infection. A high pH could indicate the presence of a urease-splitting organism and should raise suspicion for struvite stones. With an elevated serum calcium level, suspect possible hyperparathyroidism and obtain a serum intact parathyroid hormone level. Patients with hyperparathyroidism are at greater risk for developing calcium phosphate stones. When a stone is present, a stone analysis should be performed at least once. A stone composition of either uric acid, cysteine, or struvite will suggest metabolic or genetic abnormalities. A calcium phosphate stone is most likely to be associated with comorbid conditions including hyperparathyroidism, renal tubular acidosis type 1, and medullary sponge kidney. The presence of multiple stones may also suggest a greater risk of recurrence. In the case of patients who are high risk or recurrent or first-time stone formers, additional metabolic testing should be done. This should include 1 or 2 24-hour urine collections while the patient is on a random diet and analyzed for the following: total volume, pH, calcium, oxalate, uric acid, citrate, sodium, potassium, and creatinine. For stone formers, it is advisable to recommend a fluid intake that will allow for the patient to achieve a urine volume of at least 2.5 liters daily. Patients with calcium stones and a high urinary calcium level should limit their sodium intake to less than 2 grams per day and consume 1,000 to 1,200 milligrams per day of dietary calcium. Patients presenting with calcium oxalate and high urinary oxalate should limit their intake of oxalate-rich foods including soy, beets, spinach, and potatoes, and maintain a normal level of calcium intake. Patients with calcium stones and low urinary citrate should increase their intake of fruits and vegetables and limit non-dairy animal protein. Patients with uric acid or calcium stones should also limit non-dairy animal protein. Patients with cysteine stones should limit sodium and protein intake. Some recommended supplements for kidney stones are moonstone, which helps prevent the recurrence of kidney stones, and KSP that aims to balance urine pH. Now that we've covered workup and lifestyle modifications for kidney stones, we will move on to some pharmacologic interventions. Patients with recurrent calcium stones and elevated urine calcium levels should be offered thiazide diuretics. Chlorthalidone is preferred over hydrochlorothiazide due to its longer-acting half-life of 48 hours versus 8 to 15 hours. For patients with recurrent calcium stones or low urinary citrate levels, potassium citrate therapy should be offered to reduce the risk of developing recurrent stones. For patients with recurrent calcium oxalate stones who also have hyperuricosuriia and normal urinary calcium, allopurinol is the recommended treatment. Thiazides and potassium citrate can be considered for empiric treatment in recurrent stone formers without metabolic abnormalities. Patients with uric acid and cysteine stones should be offered potassium citrate. Primary treatment for uric acid stones is potassium citrate. allopurinol is only used as adjunct therapy for uric acid stone formers if uric acid levels in the urine are not adequately responding. Alone, as a first-line therapy, it will not prevent stones that are caused by low urinary pH. For patients with cysteine stones who are unresponsive to dietary change and urinary alkalinization, cysteine-binding thiol drugs are recommended. For residual or recurrent struvite stones, all surgical options should be used and exhausted before offering acetohydroxamic acid as a treatment option. Any patients who are prescribed medications should have their blood tested periodically to monitor for any resultant adverse effects. In the case of stones that are too large and need to be removed, surgical options are available to those for whom the benefits far outseed the risks and burdens. According to the American Urological Association guidelines, there are various methods of imaging that can be used to obtain information on stones. However, non-contrast computed tomography scan is the modality of choice for patients prior to undergoing the following surgical procedures: percutaneous nephrolithotomy, ureteroscopy, and shockwave lithotripsy. In a patient where there is suspicion of reduced renal function, serum electrolytes and creatinine should be ordered. Prior to surgical treatment, a urinalysis should be obtained to minimize any risk of infections. In patients with anemia, thrombocytopenia, or infection, or those at high risk for hemorrhage, additional studies need to be obtained, including a complete blood count and platelet count. Any stones that are complex should have further studies done in order to determine the best approach for treatment. As seen in the image, this CT scan is from a patient who has a history of kidney stones. You can see some hydronephrosis in the left kidney. Although not shown, the reason for hydronephrosis in this image is the ureter being obstructed. Returning back to our patient, an abdominal pelvic CT scan was ordered, revealing the presence of kidney stones in both the left kidney and left ureter. The right kidney and ureter were spared. A 24-hour urine test revealed both a urine pH of 6.5 with elevated levels of cysteine. The renal ultrasound also aided in confirming the presence of non-obstructing kidney stones. With this information, what would be the next best steps in treatment and management? Any patients who have uncomplicated ureteral stones that are less than 10 millimeters in size should be offered the option of observation, as stones of this size may pass on their own. Smaller stones are more likely to pass quickly than large stones. Those with stones of similar size that are more distal should be offered MET with alpha blockers. Re-imaging should also be offered prior to surgery if there is suspicion of stone movement or spontaneous passage. As a general rule, 50% of 5 millimeter stones will pass spontaneously, with an average passage time of about 10 days. The two most common surgical stone removal methods are ureteroscopy and shockwave lithotripsy. Both have their benefits. Shockwave lithotripsy has the lowest morbidity and complication rates, but ureteroscopy has greater stone-free rates after a single procedure. Ureteroscopy is the preferred option for ureteral stones. The risk of stricture after ureteroscopy varies and can be based on factors such as stone size, instrumentation, and impaction. Shockwave lithotripsy is a good option for stones less than 1.5 centimeters and in the renal pelvis or mid and upper pole. Contraindications to shockwave lithotripsy include pregnancy, anticoagulation, or coagulopathy. Lower pole stones are harder to treat due to the acute angle of the ureteroscope. Stenting is a procedure that should not be used prior to shockwave lithotripsy treatment and may be omitted for patients meeting the following criteria: suspected ureteral injury during RS, no evidence of ureteral stricture of anatomical impediments, or those who don't have planned secondary URS procedure. Stenting should be performed routinely prior to URS, and alpha blockers and antimuscarinic therapy can be used to reduce post-procedure discomfort. Ureteral stents are placed in the context of stones for the following: acute infection. Urgent stenting is indicated for patients who are obstructed and infected. Stone surgery is contraindicated in the face of infection. After ureteroscopy, stents are placed to allow for ureteral rest and to prevent obstruction from post-surgical ureteral edema. If access to the stone is not feasible, either due to an impacted stone or narrow ureteral caliber, a stent is placed to allow for passive dilation of the ureter. This staged approach allows for successful access to the stone or kidney, usually 2 to 4 weeks later. Stents after ureteroscopy are usually left in for 5 to 7 days. More often, a string is left attached so that patients can pull the strings and stents out themselves. If it is felt that the ureter is tight or there is a ureteral injury, we sometimes leave stents in for a longer period of time to allow the ureter to heal. Stents can stay in place for up to 4 to 6 months before they need to be removed or changed. Percutaneous nephrolithotomy is the placement of a scope through the back to access the stone. Common indications include stones greater than 1.5 centimeters, staghorn stones, patients with urinary diversion, which means no bladder to access the ureter, ureteral stricture that prevents the retrograde approach, and calyceal diverticula. The use of PCNL, laparoscopic, open, or robotic-assisted surgery can be used in patients who are unlikely to have successful treatment with URS and/or SWL. These procedures should not be offered as first-line therapy, except for rare cases or anatomical abnormalities. In patients with obstructive stones or suspected infection, the use of a stent or nephrostomy tube is necessary to drain the collecting system and delay stone treatment. Other guidelines to follow in patients who are symptomatic are as follows. If the renal stone burden is less than 20 millimeters, shockwave lithotripsy or ureteroscopy can be offered. But if the burden is greater than 20 millimeters, percutaneous nephrolithotomy should be offered as a first-line therapy. Endoscopic treatments can be offered for patients with residual stone fragments following treatment of shockwave lithotripsy, ureteroscopy, or percutaneous nephrolithotomy. After stones are removed, they should be sent for composition analysis. Based on urine culture results, antimicrobial prophylaxis can be administered prior to starting interventions. In the case of endoscopic intervention, due to the high risk of urosepsis in patients with infection, stone removal can be aborted and appropriate draining can be performed. Congratulations! You made it to the last slide of the patient case. Stone analysis revealed that the stones found to be in the left kidney and obstructing the left ureter were cystine stones. Genetic testing also revealed that the patient has autosomal recessive cystinuria. This affects cystine transport, leading to excessive urinary cystine levels. The patient was started on oral citrate ER and Thiola. The obstructing stone was also removed through ureteroscopy. Management of the patient going forward includes following her condition with labs and imaging, trialing different medication regimes, and counseling on lifestyle changes. This patient continues to develop stones despite adhering to customized treatment. Although at most recent follow-up, the patient is stable. In the case that a patient's stones did not require surgical management, a single 24-hour urine test should be ordered to identify any risk factors that may cause recurrence within 6 months of starting treatment. Urine specimens should be continued annually and may be increased in frequency depending on the stone activity. In treatment-resistant patients, a stone analysis may be needed. Struvite stones are especially important to monitor due to their associated risk for reinfection with urease-producing microorganisms. Repeat imaging is also recommended to monitor for any additional stone growth or new stone formation. This can be done through plain abdominal radiographs, low-dose CT scans, or renal ultrasound. Thank you for watching this presentation. We hope you found it informative and entertaining. We would like to extend a very special thank you to Dr. Helen Kuo of the Idaho Urological Institute for generously sharing her time and expertise with us.